Good afternoon and welcome to today's complimentary webinar titled Mental Health Parity, Achieving Equality in Care. This webinar, sponsored by RegQuest, is the second in a series of 3 that will be provided focusing on various aspects of the medical management industry. Today's webinar will be recorded and available to RegQuest subscribers. Following today's webinar, we will have time for a brief question and answer session with our guest speakers. My name is Katie Spivey and I serve as Senior Legal Counsel of RegQuest. I started working for RegQuest parent company, Schooner Strategies, in 2011 and returned to work with our CEO, Gary Carneal, this past August after spending 2.5 years working on Capitol Hill. I worked for 3 different congressmen, focusing primarily on healthcare policy. In my current role with RegQuest, I oversee daily operations, the creation of new content, and customer and web support. With that, I'd like to take a moment to introduce today's expert speakers. First, I'd like to introduce Tim Clement, Policy Director of Scattergood Foundation and Parity Track. In his role, Tim analyzes legislative, regulatory, and statutory policy related to behavioral health, particularly policy pertaining to mental health and addiction parity. Tim has a master's degree from the Drexel University School of Public Health with a concentration in health policy. He contributed all of the legislative, regulatory, and statutory content for the parity reports found on paritytrack.org. Additionally, Tim is currently writing model state parity legislation in collaboration with the American Psychiatric Association, Community Catalyst, Mental Health America, and the National Alliance on Mental Illness, and drafts model regulatory documents for state regulatory agencies responsible for enforcing the federal parity law and similar state laws. Thanks for being with us today, Tim. I'd also like to introduce Gary Carneal, President and CEO of Schooner Strategies, co-founder of RegQuest, and Senior Policy Advisor of the Kennedy Forum. Mr. Carneal has held a number of positions where he has helped form national standards for utilization management programs. In the early 1990s, he served as Legislative Counsel of the NAIC, where he served as primary staff drafting the Model Utilization Management Act, now called the Utilization Review and Benefit Determination Model Act. From 1995 to 2005, he served as President and CEO of URAC, where he oversaw the development and/or revisions of accreditation standards covering utilization management, case management, disease management, external review, and nurse triage programs. Again, thank you for speaking with us today. Before we begin the webinar, I'd like to go over a few housekeeping items. As I mentioned earlier, today's webinar is the second in a series of 3 complimentary webinars sponsored by RegQuest. Our first webinar examined utilization management practices and trends. Our third and final webinar will explore external review programs. For more information on these sessions or to register, please go to www.regquest.com/events. For those participants with us today who are not members of RegQuest, I will now provide a brief overview of our website and services. RegQuest is a regulatory compliance resource that details many of the business, legal, and regulatory forces directly impacting the medical management system. This user-friendly tool serves as a definitive guide to help users understand how these changes affect the healthcare system and your business. Current modules include utilization management and external review. Our third module, focusing on grievance and administrative appeals, will go live this summer. RegQuest is adding additional modules on state mental health parity laws, case management, and telemedicine later this year. This slide shows a partial example of the information available to subscribers on RegQuest Utilization Management module. Each state survey includes information on the scope and applicability, regulatory information, program requirements, reviewer qualifications, reviews and appeals, and registration and licensure requirements. After gathering this information, we then send it directly to regulators for peer review. We keep this information up to date and send out push alerts to our subscribers alerting them of any changes in statute or regulations. For more information on RegQuest, please feel free to contact me, Katie Spivey. My contact information will be displayed later on in the webinar. And now I'd like to ask Gary Carneal to provide some general background about the Kennedy Forum and the work they are doing on mental health parity. Gary?
Hi, Katie. Thank you so much. And Katie, Tim, and I are looking forward to today's presentation, and we're going to try to keep it interactive. Just before I talk a little bit about the Kennedy Forum, it's been interesting in the different positions. I'm actually beginning to feel like a little bit like an old timer, having been around now for a quarter century, developing a lot of the model managed care laws and medical management standards when I was at URAC. And I think that the baseline research that RegQuest offers is just so important to promoting not only kind of more efficient business flows and risk management strategies, but a more informed public policy discussion. And so RegQuest has kind of taken the formulas that I used at the American Association of Health Plans, NAIC, and URAC to really lay the groundwork of really what's the existing kind of state of regulations for the different components of health insurance, particularly today related to medical management. We're truly, I think, in a transformational time in a post kind of healthcare reform environment where we're still trying to implement key elements of the Affordable Care Act, and it's really kind of transformational. I think that the federal mental health parity law and some of the state accompanying regulations has really kind of opened up a dialogue, a moment of introspection, no matter what your stakeholder perspective, whether you're an industry representative, provider, consumer, or legal advocate. And it's been my pleasure to, as one of many important activities, to join the Kennedy Forum to provide some guidance and support as we begin to work through some of these dimensions on mental health parity. And I think one of the exciting things about the Kennedy Forum, which Patrick Kennedy founded back in 2013, is a really kind of the multidimensional approach that we have to addressing behavioral health issues. So we have 5 policy pillars that we put together. The first pillar, which is we're going to focus mostly on today, is parity compliance. And as Tim and I will comment on, it's just really how we kind of make sure we can cross the bridge to a more level playing field between how behavioral health services are offered and medical surgical services, and there certainly are some legitimate challenges that we all have to work through. But that's not the end of the story. Really, we're talking about a system that has traditionally been fragmented and siloed on the delivery side as well. So the Kennedy Forum has put together a platform. We've hosted, by way of example, 15 or so focus groups in the past year, some of the nation's leading thought leaders from all different types of organizations. And so Pillar 1 includes parity compliance. Pillar 2 deals really with measurement-based care and provider accountability. And you'll notice on our website there's a recent issue brief on using symptom rating scales as a way to kind of create more of an empirical feedback loop when you're dealing with mental health or substance abuse issues. Then there's the whole issue of integration. So among other options, there's an issue brief that we've published on collaborative care coming out of the University of Washington, really since most Americans do not go to a behavioral health professional, 80% or so go to the primary care physician, leveraging the primary care physician setting as a way to basically screen for depression, anxiety, and also make sure it's a conduit to when more serious mental illnesses arise. The fourth pillar is technology, and we just wrapped up a series of focus groups, one looking at the emerging array of amazing treatment interventions, everything from smartphone apps to modular devices that read alpha waves in the brains and how that can supplement traditional clinical practice. And in addition, another focus group on enterprise enabling applications, how we link together technology platforms, interoperability, et cetera. That issue brief will be published in the next month or so. And then finally, Pillar 5, which is on brain fitness and health, which we've had a series of amazing focus groups and just making recommendations about how we do a better job maintaining that very important organ in our body. And among other recommendations, the Kennedy Forum is suggesting we really make more of an investment in early childhood education to make sure that there's more focus on the brain. Next slide. So there's a lot of different resources you can pull at the www.kennedyforum.org. And among other things, I would like to point you to the Parity Resource Guide, which is under Pillar 1. That was a publication that was published June of last year with a effort between the Parity Implementation Coalition and the Kennedy Forum, and really kind of provides a nice overview for anybody who needs a more technical approach to mental health parity and understanding the appeals process. And then, as we'll talk to in a moment, there's going to be a consumer version of that resource guide published shortly. And then why don't we go ahead to the next slide, and Tim could talk a little bit about Parity Track, which is a major resource for the Kennedy Forum and the Scattergood Foundation.
Well, thank you, Gary, and thank you, Katie, for putting all this together. It's a pleasure to be on this webinar. So I'll just talk a little bit about Parity Track and what the project is, and I think that's the key distinction to make with Parity Track is that it is both a website, paritytrack.org, but there's also a project that not only seeks to track implementation of the federal parity law and similar state parity laws, but also create solutions that can help regulatory agencies, legislators, and the industry come into compliance in a way that makes sense for all parties involved. So what we do at paritytrack.org is we've tracked all the trends, all the things that have occurred at the legislative, regulatory, and legal levels in parity implementation at the state level for all 50 states since the passage of the federal parity law back in 2008. So at paritytrack.org and the parity reports, you'll find 50 state reports for each state in those 3 different categories. So there'll be a different report for legislation, a different report for regulatory actions, and then a different report for legal actions. Now, of course, keep in mind for legal actions and litigation, there's not every state has a report because there hasn't been legal action in many states. But for the legislation and the regulatory reports, there are reports for almost all of the states because there has been quite a bit of action in all of those levels. So in addition to tracking that, we also create model legislation aimed to sort of fill in some of the loopholes in the federal parity law, but also provide much more precise guidance and definitional clarity, so we can just help all parties involved in the regulatory side and also in the insurance and the industry know exactly, what are the T's to be crossed and the I's to be dotted in terms of coming into full compliance with the federal parity law. So that's just a little update on our project and what the website itself does. Next slide, please.
Wonderful. Well, thank you for that, Tim. So now let's get into a deeper dive of mental health parity, and let's begin with an overview of the Parity Challenge and talk a little bit about why this is an issue we should be discussing. So I'll turn it over to you all.
Okay, thank you, Katie. So I think the first basic question to ask is, what is parity? Just in not necessarily the federal parity law, but just the concept itself. And it's a very simple concept. The concept that insurance coverage for behavioral health services should be the same as insurance coverage for other medical conditions. And the key phrases are same terms and conditions and no more restrictive. And that goes for both as plans are written, but also more importantly as in operation. So that's the general concept behind parity is that things should be equal. And that doesn't mean they have to look exactly the same. They just need to be administered in a similar fashion. Next slide. So, of course, in understanding what parity is, it's important to understand there is the federal parity law, which you'll hear me refer to the federal parity law quite frequently. And the federal parity law is the Mental Health Parity and Addiction Equity Act of 2008. Of which Patrick Kennedy was the lead sponsor of that bill. And also what's important to understand is there are many similar laws at the state level that either are called explicitly parity laws like the California Parity Act or the Kansas Parity Act, but some of them are not necessarily called parity laws, but they have the same effect, like Timothy's Law in New York. And the reason that parity is such an important thing is that for many years, people have not expected the same standard of care in terms of for behavioral health treatment as they have for other medical treatment. But now it is something that, as we see with the opioid crisis that is sweeping through the country right now and claiming many lives, it's important that people are able to get adequate treatment for their behavioral health conditions and that expect and understand that they deserve that treatment. So then, right now, parity can be seen almost as a life-saving type of concept. And then another question to consider is, what does a parity violation look like? And I'll get into a little more detail on that in the next slide. But there's some simple ways, like differences in co-pays or co-insurance rates. But then we're really finding the challenges in the much more complicated things in terms of things like network adequacy, clinical medical management standards. So those are some things where we can find, if we find disparate application in those things, that could potentially lead us to a parity violation. And then it's also very important that, and this is one of the things that consumers and individuals with behavioral health conditions struggle with the most, is there's a very precise protocol you must go through if you think potentially there has been a violation, and Gary will get into this a little bit later, but you have to understand and then actually go through the appeals process, and there's many different levels to that process. I'm sure most of you on the webinar understand. But that's a very important thing that it's generally poorly understood by many individuals who may have experienced something that could be a parity violation. And then, of course, the last challenge that I think is maybe the biggest challenge that we face is accessing parity experts, like legal advocates, because the term parity expert, there just simply aren't many of them in the country. I mean, I probably know all of them and can name them off the top of my head. So that's something where that's the challenge that we really have, is there's not enough expertise on the topic, although I do think that's been changing in recent years. And Gary, I know that you wanted to chime in here.
Yeah, it's so interesting because when we talk about mental health parity, there are so many kind of overlapping and interdependent elements that come into play. You mentioned, for example, network adequacy. You think about it, earlier attempts of parity would be, mandated benefits, and then you have, in the 70s and 80s, the emergence of, through managed care, the corporate practice of medicine. So as we begin to look at the medical necessity determination process, it begins to open up, old discussions about really what is the role of the corporate practice of medicine in terms of making sure the right care is delivered to the patient at the right time, but that's within the realities of a health insurance policy and general cost containment. And then just in terms of the kind of connection or symbiosis between a parity and, for example, the traditional utilization management appeals process, which we'll talk about more in a moment. So, for example, in most cases, a adverse benefit determination related to a potential parity violation will probably be resolved in the appeals system. We'll talk more about that again in a second. But the question is, when and where does a parity appeal get filed, and how much additional work is that in terms of working through the specifics? So I think it's really interesting that as we think about this as a specific instance, it really kind of opens up the whole kind of array of medical management issues. And one of the interesting things that RegQuest did is it published about a 60-page report on the utilization management system. These are regulations that are a quarter century old, and where are they effective and where are they no longer effective, and what are the opportunities as, for example, the system, not only with parity, moves to genomics and other types of emerging, complex condition management, other types of interfaces that really kind of call into question the traditional ways of doing business. So I think on the one hand, it's frustrating to have to deal with the specifics sometimes. On the other hand, I see this really as a point of really some exciting public policy debate going forward.
Well, thanks, Gary. That was really helpful insight, and I think that's a great point you made about the utilization management system. I think that what we'll find, and I hope we can help you understand during the rest of this webinar, is that I think the bulk of what we see in terms of parity, the heavy lifting, it's going to be within the system. So I think that's really, this isn't just a parity discussion, it's really a utilization management discussion as well. Next slide. Okay, so this slide I'm just going to explain briefly what are the title of the slide is NQTL, and of course that stands for non-quantitative treatment limitation, and that's really, I think, the heavy part of this discussion. But first we'll talk about quantitative treatment limitations, financial requirements. Those are things like outpatient visit limits, inpatient day limits, any other limits that can be measured numerically, and of course co-pays, co-insurance, deductibles, other out-of-pocket expenses. So all of these things have to be equivalent under the federal parity law and state parity laws. What we've seen over the course of the last 8 years since the federal parity law became law is that for the most part, I think plans are largely in compliance with this. They've done a great job in making these things equal, whereas, just as recently as 10 years ago, in most states, you would see very, very different limits, 30 visit outpatient visit limits for, behavioral health treatment, 20-day inpatient stay limits. So like those things have mostly disappeared, and of course there are a few troubling exceptions, but for the most part, the industry's done a really good job in getting into compliance with that side of things. Now, when we get into the non-quantitative treatment limitations, these are a lot of the medical management protocols like prior authorization, utilization reviews we just talked about, fail-first protocols, concurrent and retrospective medical necessity reviews, and also things like geographic restrictions on care. Those are the things that what's important to understand about this is it's not just that these things have to be the same. It's not that whether or not you apply the NQTL to both medical and surgical care and behavioral health care, but it's also how they are administered in operation. That's really important. That's where we get to the more challenging aspects of getting compliance, because, and frankly, this is where there just simply hasn't been enough regulatory precision in terms of defining some of these terms and defining some of the processes, strategies, or other evidentiary standards or other factors used to apply the NQTLs. That's where we're really getting to the challenge of seeing, is that being done the same way for the medical and surgical side as it is for the behavioral health side? So that's really where we're seeing some of the difficulties. And I know that for advocates and the industry alike, we'd really like to see a little more guidance on that from the regulatory side of things. But so anyway, NQTLs are really the key term to think about when you're thinking about parity. Next slide, please.
Great. So I think that background provides us with a great starting point to go over some of the regulatory vehicles that kind of oversee mental health parity. So now let's begin with looking at the federal oversight. So Gary and Tim, I'll turn it back over to you.
So this is Gary. So of course we all work and support a very dynamic insurance and healthcare delivery system and marketplace. But of course, this also leads to a dynamic set of regulations. And so for those of you who've been around for a couple of decades, we've all seen different ways of regulations back, in the 70s and 80s with the advent of the Federal HMO Act and utilization management regulations in the late 1980s, early 1990s. There was a time where enabling legislation was more comprehensive, and of course, building upon the tradition of insurance regulators that really, even before the 1970s, focused on solvency requirements. Of course, what's happened is that the health plans have become more sophisticated, more dynamic in their offerings. Everything from, again, different types of medical management, population management strategies to more advanced, financial, transactions to again, more complex condition management approaches to healthcare. So regulations have taken us only so far, and that's further exacerbated by the fact that you do have a lot of different marketplaces that are, since we don't have a single payer system, we have actually a very multidimensional marketplace with lots of different regulations, depending on actually how the coverage or the risk arrangement is agreed to and provided either at the state or federal level. And from that, you have just an array of different insurance types and different types of regulations. And as Tim will be talking to in more detail, sometimes you have a partnership that works pretty well between the federal and states, and sometimes you have one level of government taking much more of a lead than the other. But as we kind of talk about parity, you've got to remember that we're kind of in a fragmented regulatory environment to begin with. And again, the notion of federalism, working with the National Association of Insurance Commissioners and other standard-setting bodies at the state level, again, sometimes they play a leadership role, sometimes they don't, sometimes the federal government does. Next slide. The other thing to keep in mind that regulations is much more dynamic than just a statute and then the key state or federal agency issuing regulations. So we have an array of different sources of regulatory guidance, which we're all familiar with. We were most recently reminded of that, for those of us who are tracking pretty closely, with the federal government's issuance of additional frequently asked questions on April 20th, which we'll talk about it in a minute, and then just kind of the array of court decisions and Attorney General fines and audits. So we really have kind of this ecosystem that's pretty, again, dynamic. So part of this is working proactively and creating carrots. One of the things I take some pride in is when I was at URAC, I was able to bring 18 different accreditation programs to market, and a lot of it was with the set of a broad-based set of stakeholders where we were able to plug in the gaps of regulations. So, for example, URAC came to market to develop or launch case management standards where there really wasn't any clear enabling legislation, and we were first to develop national standards for external review when that was emerging. So part of this is making sure we're working with all these different channels and sources of guidance in a way that best serves the patient and best keeps the industry healthy, and making sure that, again, in the end of the day, consumers are protected. Next slide. So as we drill down a little bit more and talk about the Paul Wellstone, Pete Domenici Mental Health Parity and Addiction Act of 2008, which Tim referred to, we need to remember that ultimately the statute was geared towards providing requirements for plans to not apply financial requirements or treatment limitations that are different between the mental health or substance abuse disorder arena when compared in contrast to the medical surgical benefits. And again, there was a time when carve-outs were encouraged, and there was different ways of approaching it. But I think we've agreed that the brain and related the comorbidity components of behavioral health issues, it's in some respects, no pun intended, a no-brainer that we do begin to really integrate treatment strategies. As a quick aside, it's been fascinating to those of you who are with health plans or provider systems, and when you look at the move of being able to create a customized care treatment plan that controls for the comorbidities, we all know that depression, anxiety can be a major, if not the major comorbidity when you're dealing with a patient that has congestive heart failure or diabetes or what have you. So it does make sense to begin to create these more integrated approaches. So the law really aims to address both the financial or QTL aspect of the decision-making process, which Tim alluded to, and the non-financial or the non-quantitative approach to make sure, again, there's parity or a level playing field. As many of you know, MOPIA supplemented the earlier law, the Mental Health Parity Act of 1996, which really focused on parity with respect to aggregate lifetime and annual dollar limits for mental health benefits. So what MOPIA did is really kind of expand the whole scope and landscape of how parity is achieved. Now, MOPIA was adopted kind of in phases. There were two sets of well-known regulations, and then you also have, as Tim will talk about in more detail, kind of the expansion of this at the state level. But the initial statute in 2008 applied to employer-funded health plans with more than 50 insured employees, Medicaid managed care plans, and children health insurance programs. And then with the adoption of the Affordable Care Act in 2010, particularly with mental health and substance abuse services being one of the 10 essential health benefits, the scope of parity functionally expanded to cover non-grandfathered employer plans with less than 51 employees or small group coverage, non-grandfathered individual market plans or exchange plans of non-group, Medicaid alternative benefit health plans, and then plans offered through the insurance exchanges. So we began to see the scope expand, and then there were other areas that were originally carved out which are now being addressed through additional regulations. So for example, recently CMS issued regulations for Medicaid, traditional Medicaid health plans, and for TRICARE, which are still under public comment. And then you had, for example, through the Federal Health Employee Benefit Program, even though they weren't specifically named in the statute, you had OPM basically said that for all intents and purposes they will comply with that. So there are a couple still exposure points such as Medicare and VA plans, but the point is that with the dynamic way, you got to really kind of make sure which federal and state regulations are applying. There's still some exemptions, including local, state, and self-funded government plans that may apply for an exemption through CMS. And then, as I said, with Medicare plans. And then there historically were some cost exemptions. So if a health plan experienced cost increases of more than 2% in the first year and 1% in the following years, they could file for an exemption. And of course, the other thing to keep in mind is before the ACA, there wasn't a mandate per se to cover behavioral health services, but if you did, then it had to be on a level playing field. Of course, again, the ACA kind of changed that a little bit with the Affordable Care Act. Next slide. So what's interesting is that as we begin to settle down in terms of the final regulations going into effect, and then the kind of action moving a little bit to the states, but then the federal government still continuing to provide guidance on April 20th, we get to kind of drill down, and Tim and I will be talking a little bit more about some of the issues. You have the 6 classifications, which is an important concept, so that when you do these comparability analysis, you have to break it down to one of these 6 domains: inpatient network coverage, inpatient out-of-network, outpatient in-network, outpatient out-of-network, emergency care, and prescription drug coverage. And then, there are a lot of issues, again, which we'll talk about in a minute, in terms of, what does it mean to do a comparability test? What does it mean to disclose effectively to the patient or attending provider? Transparency issues. And then there's the issues of standardization. What we have now is a lot of states, and whether it's a state insurance department or other agency or the Attorney General's office, using different ways to audit for parity compliance, which again we'll talk about more in a minute. So with that, I'll turn it back over to Tim.
Yeah, thank you, Gary. So that was very helpful to walk us through the federal level on this, and I think that's an important distinction to make. Is really, since the Affordable Care Act, there hasn't been any additional federal legislation that has affected parity. There are a number of federal bills currently under consideration in Congress that do have some provisions related to parity, although it's mostly related to enforcement of the federal parity law and guidance that those bills would like to see the federal regulatory departments take, specifically the Department of Labor and the Department of Health and Human Services. So really, most of the action has taken place at the state level since 2010. Really, all of the action has taken place on the legislative side of things. And there actually has been quite a great deal of legislation since 2010 at the state level. Hundreds of bills have been introduced and dozens have passed. And I'll get a little bit more into that in a bit. And if you wonder why is this map that you see colored the way it is part of our Parity Track project and tracking the implementation of parity at the legislative and regulatory levels. We have a color-coded system for grading how well those states are performing. Yellow means good, gray means okay, and black means not so great. So you'll see at the legislative level, most states are actually doing something about this, and some are doing a really good job in terms of filling in loopholes and providing clarity. There are some states that are not performing so well, but for the most part, states are taking action at the legislative level and are introducing some really fascinating bills that we've sort of rolled into our model legislation that we've created. Next slide, please. Now, of course, if you'll keep that color-coded scheme in mind, if you'll notice the regulatory side of things, we see a lot of black on that map, some gray and a little bit of yellow, but this is where we're seeing the biggest challenges. There's been very limited regulatory action by the Fed, certainly by the Feds, and also by the states. And when we say regulatory action, that doesn't mean fines or coercive actions. It just means it could be something as simple as issuing guidance and clarity, because that's something that's very much lacking. And I'll get into an example of what's a good example of providing guidance and clarity. And again, it's largely a complaint-driven system that we're relying on. So that's what the regulatory agencies are doing, and that's their sort of pushback. Is they say, well, when we get parity complaints, we'll look into it and see what we can see on that. The problem is that, according to a study by the American Psychological Association from 2014, only 4% of the general public knows about the federal parity law or the concept of parity in general. So of course they're not going to get any complaints about parity because nobody knows what it is. So as long as it's a complaint-driven system, you're not really going to see much regulatory action. That's one of the biggest areas where the regulators really need to come up to speed. And of course, as Gary alluded to earlier, in terms of doing those comparisons for the non-quantitative treatment limitations and the application of medical management practices, there really has not been adequate guidance from the federal agencies or state agencies on how exactly that should be done, or even how certain terms are defined. For instance, there's some terms like processes, strategies, evidentiary standards, or other factors. Well, what exactly does that mean? And I know the industry has asked that question, and as of today, the regulatory agencies have not provided adequate responses, and that's one thing we're working with at the Parity Track project, is to help provide those regulatory agencies with some of the definitional clarity on that. Next slide, please. So you also have state parity laws, and I know we've talked a little bit about that. In fact, almost every state in the country, I think every state except Wyoming, has some form of a parity law or at least a behavioral health insurance coverage law. Now, as we stated earlier, the federal parity law sets the floor, so to speak, for parity in every state. So any state law that's weaker than the federal parity law, that's generally irrelevant. But so as laws as a whole, taken and compared side by side, most state parity laws are generally weaker than the federal parity law, but some are stronger. Like Illinois, for instance, has a parity law that is definitely stronger than the federal parity law, and I'll explain that in a second. And then some state laws are weaker than the federal parity law, but strong, generally speaking, but stronger in certain areas. For instance, Kentucky has a parity law that's not very strong, but it's stronger than the federal parity law in that it defines mental illnesses and substance use disorders as all conditions listed in the International Classification of Disease or the Diagnostic and Statistical Manual of Mental Disorders. So that's something that the federal parity law does not do, whereas that is in fact the case in Kentucky. So that's an example of a state parity law being weaker as a whole, but in one narrow slice, it's stronger. And so that gets to the next point there is, because most plans in the country, except for some of the exceptions that Gary noted, like Medicare, most plans do have to comply with the federal parity law. So if a state law is weaker, that doesn't matter. So most of those laws are less relevant, except in the areas where they are stronger, because one of the important things that the federal parity law does is it does not preempt state laws that are stronger than itself. And so some of the recent state legislative trends, or what we're really seeing is they're augmenting the federal parity law, filling in loopholes, and then requiring state regulatory agencies to show their work, basically, show us what you're doing. That's something they've done in Connecticut and Illinois, they've done that, Rhode Island, they've done that. And what we found is when there is legislation and making requirements of the state regulatory agencies, that's when we actually see the agencies start to provide a little more clarity and start to do their jobs a little bit better. Next slide, please. Okay, so on Parity Track, we did our 50 state reports for legislative action, regulatory actions, and legal actions, which I alluded to earlier. So and I've mentioned how that process worked out a little bit. So what I want to do is just go through a few examples of some of the promising practices we've seen from around the country. So next slide, please. So, for instance, example number one, Illinois, their state law, as I mentioned earlier, goes well beyond the federal parity law and applies protections to plans that are not covered by the federal parity law or plans that can opt out of the federal parity law that Gary just mentioned. That's critical because in Illinois itself, a lot of self-insured county and municipal plans have in fact opted out of the federal parity law. However, because Illinois state parity law applies to those plans and it is stronger than the federal parity law, generally speaking, that opt-out really really has no effect on those plans at all. Another example, and this is something that is really important that has been lacking, but one of the exceptions to this is that when it comes to regulatory guidance, the Oregon Department of Consumer and Business Services issued regulations and then provided sub-regulatory guidance, which is critical to plans, showing them how they must comply with the federal parity law, the parity components of the ACA, and the Oregon State Parity Act. And it went to very, very specific and granular detail about what that meant. For instance, an example within the sub-regulatory guidance was that plans should review all of the decisions made by their independent review organizations, and if they're noticing any trends in those IROs overturning the plan's adverse benefit determinations, they should then go back in and look at their practices and make sure if they really are in fact compliant with the federal parity law and the State Parity Act and the parity provisions of the ACA. So that's something that if we could get all 50 state insurance departments to do something similar, that would be a great step in terms of providing the clarity we really need to get compliance with the law. And then California's Department of Managed Healthcare, they've fined a number of plans, which in itself isn't necessarily the important action, but what they do is incredibly important. Is they require plans to submit a detailed non-quantitative treatment limitation sheet that shows in very specific detail how it is they are or are not in compliance with federal parity law. And just requiring plans to make that kind of examination can really help provide the plans with the guidance they need to know, if they are in fact doing things the right way. Next slide, please. So there's many opportunities for states, and this is one of the great things about doing the work we did at Parity Track, is we got to sort of take a whirlwind tour throughout the country and see what are some of the promising practices throughout the states, and what are the states really doing now, and what are the progressive things they're doing to help achieve true compliance. And one thing that I mentioned earlier is pieces of legislation that require state insurance departments to address parity enforcement and consumer education, because what we found is if there is not legislation in place or a statute in place that requires insurance departments to, in fact, check for compliance with the federal law and similar state laws, the departments simply aren't doing it. So legislation requiring that, and then also requiring them to educate the public, is something that we've seen. There's a great need for that, and certain states like Illinois, Connecticut, Massachusetts have sort of taken the lead on that. And of course, bills that fill in gaps in state law and augment the federal law, like what I just mentioned in Kentucky with the ICD and DSM definition of mental illness and substance use disorder, and then some of the things on the non-quantitative treatment limitation side of things, like requiring medical necessity criteria to be the guidelines of the American Society of Addiction Medicine. That's something that we've seen in Illinois, we've seen that in Rhode Island, we've seen that in Connecticut. And then also another thing that we've seen really in one state, but I think we're going to see it in more states, are bills that require insurance plans to demonstrate how they comply with the federal parity law and similar sections of state law, and not in a coercive or punitive way, just simply in an educational way, so there can be corrective action. Instead of fines, just making sure we get in there and get it right. The one state that we've seen do that so far is Massachusetts. And of course, the shortcoming we saw there is they did not provide enough clarity in that piece of legislation, and then the subsequent regulations that followed. So the plans were sort of not really sure what exactly they were supposed to submit, so that hasn't necessarily been a useful endeavor. But it is a very necessary step. It just needs to be that legislation needs to be designed in a very precise and specific way, which is part of what we've done with our Parity Track model legislation. And then, of course, regulations and bulletins or sub-regulatory guidances. We've seen that in a number of states. A lot of the regulations have mimicked the federal final rules, but also some of the guidances, like what I just mentioned from Oregon. They've also done that in Washington State, where they explain to plans very specifically, this is how we're interpreting the law. This is how we're asking you to comply with the law. And of course, actively responding to consumer complaints. We've seen that in a number of states, and that's important. When you do get complaints, it's important for the regulatory agency just to check into it to see what is going on here. Is where there's smoke, maybe there's fire, or maybe not. And of course, as I just mentioned, that's not good enough. What we really need are systematic investigations, and again, not for the purpose of levying fines or stripping certification or anything like that. Just making sure that everything's done right and there can be corrective action, but not punitive action. And of course, when there is demonstrated noncompliance, there does need to be some follow-through by the regulatory agencies, because without that follow-through, it's hard to get compliance if there's no teeth behind anything. And of course, the biggest thing that regulatory agencies can do, and this is a huge opportunity for the states, is you have to look proactively for parity violations and claims denial. So for instance, if you're getting a lot of complaints to the insurance department regarding denials on grounds of medical necessity for, say, residential treatment, it might be a good thing when you're doing that to check into those claims to see is everything done in compliance with the federal parity law and similar state laws. So those are some of the opportunities we've seen for the states. Next slide, please. Now, of course, the challenges for the states. The first one is a real big one. Checking for compliance in terms of non-quantitative treatment limitation design and application. That is no simple task. It's a very complex task, and that's something simply a lot of the state regulatory agencies do not have the level of sophistication necessary to do that. So that's something that's, before we're really going to see any kind of adequate compliance checking, we're going to have to see a little more a better understanding of that on the state level. And some of that could start with federal guidance. The Federal Department of Labor could take the lead on that and help set the model for how states can do that. And of course, that leads us to coordinating with the Department of Labor and Health and Human Services, because one thing that consumers are completely flabbergasted about is there's so many different, the Department of Labor, for instance, is responsible for regulating all self-insured plans. Most consumers, first of all, those concepts don't make any sense to them to begin with, and then they don't understand whether their plan is self-insured or not. So most consumers aren't even sure which is the right regulatory agency to go to when they might have a complaint. And of course, resources. There does need to be, someone does have to do the work in terms of checking for compliance, and as of to date, not many states have really set aside any specific dollars for parity compliance checking. And then, of course, related to the first bullet point is the need for technical assistance. And that's something that we at the Parity Track Project, along with some of our partners, the American Psychiatric Association and others on the Kennedy Forum, are working to help provide that technical assistance to state regulatory agencies and also to the Federal Department of Labor. And then we've had some productive meetings with that, so we think there's some encouraging steps there. And of course, keeping laws up to date with current trends. I mean, the non-quantitative treatment limitations of today could be completely obsolete in 2 years. So we got to be careful with the laws and regulations that are in place. They keep pace with that. Next slide, please.
Okay, great. Well, that was really helpful, Tim. And speaking about some of the current trends, let's actually turn now to some of those trends that are impacting mental health parity. First, Gary, can you provide us an overview of the appeals process and tell us a little bit about how mental health parity claims fit into this overarching process? Sure,
and if I could just take a liberty and make a couple of comments before that. The other thing to keep in mind is that the Scattergood Foundation and the Kennedy Forum, and I think most stakeholders also are very interested in working with health plans and insurance companies to come up with realistic ways to comply with these new parity requirements. Think about it in terms of how the utilization management system has evolved over the years. Early on in the 70s, most of the clinical guidelines that ended up being developed by Interqual and Milliman, which is now called MCG, on the healthcare side, and later over the years, Reeds on the worker comp side, and Schmidt-Thompson on triage. Many of the standards early on were more actuarial based. And what's interesting, and to everybody's defense, is that we've had some wonderful innovation in the health plan marketplace. So, for example, the ability to have a complex condition management plan for the patient that tracks the patient through the continuum of care for every interaction with all their providers, that actually begin to put together an interface, an overlay of different specialty-based criteria that are evidence-based to better manage the patient, and with tracking through population management, better outcomes. Wow, what a cool time to be in healthcare. The challenge is, though, is that when we get to the regulatory constructs that we're talking about, there are some inherent limitations. So in some respects, you could argue that regulations have not, nor could they really keep up with some of that innovation. So this is where we get some of the dissonance and I think tension points. And of course, all of us are interested, no matter, again, what your vantage point is to try to resolve this. What's interesting is, as you look at the relationship between the states and the federal government, there was an old saying, the states were the laboratory of change with regulations. So a lot of stuff was done before the federal government adopted it in one or more jurisdictions, and I agree with that. And I also like to say that a lot of the innovation in terms of care management strategies, things like that, come from the self-funded marketplace, where there's not as much reliance on the assumption of risk and things like that. So we have, things are changing, but one of the things we've got to keep in mind is that, based on my experience, by way of example, so the first two states that Katie and I have determined adopted utilization management laws back in '88 was Maryland and Louisiana. It wasn't until 5 or 6 years later that I, as a legislative staffer at the NAIC, began drafting the Model Act. So the NAIC, as kind of a standard setting body, was 5 to 6 years behind, and by the time we started our work, over a dozen states had adopted their own regulations. So NAIC was effective to pass a Model law, but by the time it actually got adopted, a third of the states already adopted their own regulations, so there was only so much benefit in terms of the standardization. And we've seen that repeated in other circumstances. Back in the late 1990s, as kind of a second wave of protections of medical management decision-making, we saw states begin to adopt external review laws. And when I was CEO of URAC, the National Association of Independent Review Organizations approached me, and by the late 1990s, we actually were first with national standards for external review. Again, maybe a dozen or so states had already adopted laws or regulations, and then we kind of backfilled into it. And then the NIC 5 or 6 years later adopted the external review Model Act, and then you had the external review at the federal level really being codified within the Affordable Care Act. So, sometimes when we talk about regulations, there's a timing issue, and I think in some respects, we have a lot of things that are being innovative, like movements towards true integrated care, and regulations sometimes will be effective and sometimes not. I think one tension point is that when you look at the totality of all the medical management regulations, and keep in mind that, again, utilization management is really focused on the medical necessity determination. And then, for example, the model grievance or the grievance laws in most states are focused on benefit determinations, whether related to a scope of coverage or a payment issue. And then you have external review as kind of a third-party overlay. A lot of those regulations deal with, again, basic process and structure measures, a licensing schema, making sure you have a medical director, making sure that there's some basic components in terms of the appeals, whether it's expedited or standard, whether it's a prospective, concurrent, or retrospective review, whether, again, it's a benefit determination. So depending on what's actually happening, there's a lot of different ways that the appeal system or the medical management system comes into play. And as Tim alluded to, as a patient, and even as an attending provider, it's very, very confusing. So on the slide that's up before you, we have this very kind of, I don't want to say convoluted, but very complex appeals process. And I talk a lot about it in the Parity resource guide that's available on the Kennedy Forum website. And I would encourage all of you to kind of freshen your knowledge base on how this all works. And the simple answer is that a Parity appeal really is an add-on to an internal appeal or a grievance procedure where there's additional due process that's afforded to the patient or the ordering provider who's filing the appeal. But one of the tension points is really, for example, based on a consumer union study that was published last spring, a very few percentage of Americans even know, it's less than 15%, that they can file an appeal with their health plan or state regulatory agency. So this is where there's a lot of background noise in terms of that there's not a whole lot of traction on filing parity appeals. Well, you could also say the same thing in terms of the totality of the medical management system, even for a non-parity adverse benefit determination. But the bottom line is you have this ecosystem that emerges with these different layers. You have the internal appeal process and grievance process, and then you had, again, the late 90s and through the Affordable Care Act, an additional overlay of external review appeals, which is third-party reviewing, and there's a lot of public policy discussion about whether that's really an independent review or not, so I think there'll be some more debate on that. And then you have the regulatory compliance audits, and up until now, as I'm sure Tim will talk about more, there's been workarounds in terms of how those complaints have been reviewed in terms of potential parity violations. Then you have the accreditation system, which obviously I played a role in terms of supplementing regulations. By the way, in terms of parity accreditation, there's really not a whole lot out there. URAC does have some basic parity standards that are part of their health plan accreditation, but there's not a whole lot out there yet on that. And then, of course, you have arbitration and judicial hearings. The graph on the right is just a small snapshot of when I left URAC, I actually ran a private sector ACO in their medical management system, and this was actually just a sub-part of my appeals process back then. So converting from developing the standards to doing some of this in practice, I had a great appreciation for how complex this is. Now, one of the things that I would like to do, and this is more just a professional goal, is to see where and how we can automate and standardize appeals proactively. So one of the things, among many other things, is the Kennedy Forum, along with Parity Track, is alpha testing a online appeals tool solution that really simplifies how someone can file an appeal or actually register a complaint for a parity violation. And it's my hope over time that we can leverage technology to really begin to streamline some of these workflows that seem to, the old saying, people know me, say it's a rising tide lifts all boats. I think there's some opportunities to, over time, and stay tuned with RegQuest as well, to basically improve how appeals are made, which would, again, benefit everybody. I'll turn back over to Tim now.
Well, thank you, Gary. Yeah, I mean, as Gary mentioned, it is a very complex system, and so I'll just talk very briefly about auditing. So at the federal level, as I mentioned, the Department of Labor is largely responsible for enforcement, and of course that includes audits, which they do in fact do on a randomized basis to some extent, and HHS is also responsible. At the state level, you have generally, they're called market conduct examinations, and those are largely done by state insurance departments. There are a few state health departments that have some responsibility for doing audits and checking for compliance, but it's largely state insurance departments responsible. And of course, for Medicaid managed care organizations and for ABPs, the state Medicaid offices can be responsible for doing some sort of auditing and compliance checking as well. Next slide, please. And then disclosure, and what this means is disclosure to providers and patients or enrollees, some of the medical management techniques the plans apply both to behavioral health services and to medical and surgical services. The federal parity law, ERISA, and the ACA specify varying requirements for information that they must disclose. However, once you get to the level of an adverse benefit determination starting the appeals process, most plans, except for very few, are required to submit an extensive amount of disclosure information, which encouragingly, last week, April 20th, the Departments of Labor and Health and Human Services issued a sub-regulatory guidance very specifically laying out what that process is and what are the documents and information they are supposed to disclose. So that's something that, again, there hasn't been enough specificity on this, and there still isn't enough specificity, but we are moving in the right direction in terms of determining what the disclosure information is for some of those non-quantitative treatment limitation application standards. Next slide, please.
Great, thank you, Tim. So just very briefly, I'm going to discuss some of the litigation that has been going on dealing with parity. So efforts to enforce MAPIA through the court system have actually been going on since the law's inception in 2008. And some of these challenges include a federal lawsuit against Anthem Health Plans filed by the American Psychological Association, alleging that the health plan manipulated its billing codes to unfairly burden mental health care patients. Some class action suits filed against Cigna and Aetna for denying depression treatment. And as you can see from the two cases on the screen before you, Ray versus Blue Shield of California, and a federal class action lawsuit filed by the New York State Psychiatric Association against United Health Group, alleging that United applied prior authorization requirements exclusively to mental health and substance use claims, among other violations. So very, very quickly, in Ray, the court actually held that Blue Shield could not deny coverage for residential treatment for eating disorders where that treatment is medically necessary, even if the treatment was not set forth in the plan. Additionally, the court held that the California mental health parity law's list of mandated mental illness services is not comprehensive, meaning additional types of services could qualify under the parity law. In the New York State Psychiatric Association versus United Health, that will likely have some interesting implications for parity. Originally, when the case was filed in 2013, it was dismissed. However, when the suit was brought again, the court actually ruled that the Psychiatric Association had associational standing to sue on behalf of its members and rejected the insurer's argument that it could not be sued as a claims administrator. Further, the court also rejected the insurer's argument that it could not be sued as the administrator of a self-funded plan, which might open up the types of plaintiffs who can be sued for parity violations. Along those lines, a case is actually currently making its way through the California court system, Kirk King versus Comp Partners, where the plaintiff is suing the individual who performed a utilization review of his workers' compensation case, which resulted in the coverage of his psychotropic medication actually being discontinued. This resulted in further injury to the plaintiff who is actually suing, and it'll be interesting to see what kind of impact this case, if it is imbued to the rest of the utilization management system, what kind of impacts it'll have on the system as a whole. So for our last trend, Tim and Gary will actually discuss the importance of standardization, and Tim will actually give us a little bit of background on the model legislation that he's been working on.
Thank you, Katie. Yes, and I think standardization, I think if this could be summed up in one word, for standardization, the word would be necessary. We absolutely need to have standardization among the federal level and the state level. So what we've done with the model legislation, we've created that standardized template for legislation to be introduced at the state level. And of course, it can be tailored to each state in terms of the specific sections of state code it needs to go into. And of course, currently we're working with some of our partners on creating that standardized market contract exam template. And really what we want to do is provide the precise definitional terms used to measure NQTL compliance. Because I think we have to have standardization. We're not going to see any real progress.
This is Gary. What's interesting is part of the lack of standardization is based, again, going back to the theme of the corporate practice of medicine. So you had regulations up until now not getting down to the specifics of, for example, the fidelity of what came out in the April 20th guidance in terms of preponderance test and, you know, what potentially can meet evidentiary standards as disclosure. And so health plans, and it's not a criticism, but they, you know, develop their own kind of medical management workflows within their different corporate entities. And so now for the first time, there's this kind of different layer of interface about how we discuss as a society, again, whether you're a health plan medical director or a patient or attending provider or a purchaser of care, how we actually are making those decisions. And there's some philosophical issues about, again, kind of revisiting, you know, how does steerage work or doesn't work within kind of the coverage, whether it's an exchange plan or a non-exchange plan. And because of this, this is why you've had some of the inconsistency in terms of the auditing. By way of example, when you see a lot of the states, including New York's AG case and the fines they leveraged against some of the health plans, and like, for example, recent fines put out by the Maryland Insurance Administration, you can see they've kind of come up with some NQTL workarounds, if you will, not getting at the heart of, for example, the guidance in April 20th, but basically dinging health plans on, you know, network adequacy issue or inconsistent credentialing or different denial rates. So everybody, I think, would benefit from some more standardization, and I think there are different ways that would emerge: additional model regulations, maybe some of the consulting houses, accreditation, works from, you know, consumer groups, et cetera. So it's going to be an interesting period of time to see how this kind of continues to develop.
Great. Well, thank you both so much. It actually looks like we have run over our allotted time. So unfortunately, it doesn't look like we'll be able to take questions today. But to conclude today's presentation, here is my contact information for RegQuest, along with Tim's information and Gary's. For more information on Parity Track, please feel free to contact Tim. You can see his address there, tclement@scattergoodfoundation.org. And for more information on this Kennedy Forum, please feel free to contact Gary, gcarneal@thekennedyforum.org. Thank you all so much for your time today. We hope that you've enjoyed this webinar and found it helpful. Please take a moment to review our future webinar descriptions and register. Thank you so much to Gary and Tim, and everyone have a wonderful day.